Tonight, we are stepping into a respectable London pharmacy after dark. Rain shines on the pavement. Gas lamps tremble in the fog. Behind the warm glass of the shop window stand rows of elegant bottles, each promising relief from pain, fever, sleeplessness, or fear. But some contain opium. Others contain mercury, arsenic, chloroform, or powerful mixtures whose ingredients are known only to the person who made them. These medicines were not chosen by foolish people. They were used by frightened families and often prescribed by thoughtful doctors who had very few reliable ways to fight disease. Some brought genuine relief. Some opened the door to modern medicine, and some created a second illness while the first remained untouched. So tonight, we will examine 12 Victorian remedies that could be more dangerous than the illness they were meant to treat. There will be no need to hurry and no need for alarm. We will move quietly through the pharmacy, the nursery, the sick room, and the operating theater, following medicine through a century in which knowledge was changing, but certainty often arrived before safety. The pharmacy itself inspires confidence. Its counter is polished. Its brass scales are carefully balanced. Porcelain jars line the walls, and the chemist works beneath a steady amber light. Everything appears measured, labeled, and orderly. Victorian medicine was not a single collection of strange superstitions. The 19th century brought better anatomy, anesthesia, professional nursing, hospital reform, laboratory science, and the beginnings of bacteriology. Yet old theories remained beside new discoveries. Treatments passed from textbooks into households before their long-term dangers were understood. Advertising could sound as authoritative as a physician, and regulation was limited and uneven. For a sick family, refusing treatment did not necessarily feel wise. Infection could become severe without warning. Pain might last for days. Laboratory diagnosis was rare. Antibiotics did not exist, and even the cause of a familiar disease could remain unknown. A doctor who reached for a bottle was usually trying to help. A patient who swallowed its contents was often accepting the best hope available. The danger was frequently hidden in the ordinary details. A bottle without a clear strength, a spoon that was slightly too large, a dose repeated too often, or a temporary feeling of relief mistaken for recovery. Our first remedy waits in a small dark bottle beside the bed. Laudanum was a tincture of opium dissolved in alcohol. It was already an old medicine when Queen Victoria came to the throne, and during the 19th century it was used for pain, cough, diarrhea, sleeplessness, and many other complaints. Its popularity was understandable. Opium could quiet severe pain when there were few alternatives. It could suppress a relentless cough or calm an exhausted patient. In a world without modern pain medicine, a few drops might seem almost miraculous. The apothecary prepared the tincture with familiar tools: a glass measure, a funnel, a stopper, and a label. The careful ritual made the dose appear exact. But preparations were not always as consistent as modern medicines, and different opium products could vary greatly in strength. Laudanum was far stronger than some milder preparations, such as paregoric. Confusing one bottle with another could have grave consequences. For much of the century, opium products were widely available. The Pharmacy Act of 1868 placed opium and its preparations among regulated poisons in Britain. But it did not make them disappear. Families still kept them in cabinets and drawers, often beside medicines that appeared far less powerful. Repeated use carried another danger. The first dose might bring deep relief. Later, the same amount might seem to help for a shorter time. A person could begin taking more, or taking it more often, without understanding that tolerance and dependence were forming. Drowsiness, constipation, confused thought, and slowed breathing could follow. A remedy taken to restore sleep could gradually disturb an entire life. Yet dependence was not a moral failure. Many people began with a legitimate illness and followed accepted advice. The bottle did not announce how quietly a useful medicine could become a necessity. Imagine a silent parlor in the morning. Pale light reaches the curtains. The fire has gone cold, and the dark bottle remains on the table. Nothing in the room looks dramatic. That was part of the danger. Laudanum belonged to respectable medicine, domestic routine, and ordinary attempts to make pain bearable. The second remedy was less gentle in its effects, but for centuries it carried enormous medical authority. Mercury compounds had long been used against syphilis, and they remained important in 19th century treatment. One common preparation was calomel, a white powder made from mercurous chloride. It was also prescribed as a purgative and for other complaints. The powder looked clean and scientific as the chemist ground it in a mortar and divided it into folded doses. Doctors worked from theories in which forceful evacuation or salivation might show that the body had responded. Swollen gums and increased saliva could be treated as signs that enough mercury had been given, even though they were also warnings of poisoning. Victorian physicians were not completely unaware of these effects. Textbooks discussed them, and cautious practitioners adjusted or stopped treatment when troubling signs appeared. But the boundary between an intended effect and an unacceptable injury was not always where we would place it today. Repeated exposure could bring weakness, digestive trouble, tremor, changes in mood or memory, and damage to the mouth or kidneys. The patient might feel increasingly unwell while everyone wondered whether the original disease was progressing. This made treatment difficult to judge. If the patient worsened, perhaps the illness was stronger than expected. If the mouth became sore, perhaps the medicine was finally working. A harmful effect could be interpreted as evidence that the dose had reached its target. Over time, doctors compared cases and questioned aggressive treatment. The decline of mercury therapy was not immediate, and no single discovery ended it. Doubt accumulated slowly in quiet consultations and handwritten notes. Whenever the promised recovery failed to appear, our third remedy hides its danger in drops so small that they barely disturb a glass of water. Fowler's solution was an arsenic preparation first described in the late 18th century and later included in official pharmacopoeias. During the 19th century, it was prescribed for a remarkable range of complaints, including some skin conditions, asthma, chorea, periodic fevers, and certain diseases of the blood. In an elegant consulting room, the bottle did not resemble a criminal poison. It stood among accepted medicines. The physician counted drops, the patient followed instructions, and the treatment entered the rhythm of breakfast or supper. Small amounts of arsenic can have real biological effects. That is precisely why they require care. The difficulty lay in prolonged courses, uncertain cumulative exposure, and limited ways to monitor what the substance was doing inside the body. Repeated use could produce nausea, weakness, nerve symptoms, and changes in the skin. A patient being treated for a chronic complaint might acquire new symptoms slowly enough that their connection to the medicine remained uncertain. It would be too simple to say that arsenic had no place in medicine. Carefully controlled arsenic compounds still have narrow uses today, including treatment for a particular form of leukemia. The Victorian era was not merely touching a dangerous element, it was trusting broad claims, long courses, and incomplete observation. By the end of a consultation, the physician might lock the bottle in a cabinet. The action suggested caution, but the measured dose had already traveled home with the patient. The fourth dangerous remedy was sold to the people least able to tolerate it. A tired parent in a Victorian nursery might face a child who had cried for hours. The baby could be teething, hungry, feverish, or suffering from diarrhea. The mother might need to work the next morning. The entire household wanted rest. Soothing syrups promised silence in a bottle. In Britain, preparations such as Godfrey's cordial became well known. Recipes varied, but some mixtures contained opium, while other infant remedies used morphine or related sedatives. Their appeal should be understood with compassion. Parents did not need to be careless or cruel. They lived without modern pediatric dosing, dependable childcare, or a clear explanation for many childhood illnesses. Advice came from neighbors, advertisements, relatives, chemists, and physicians. A decorative label could make a powerful drug look like an ordinary comfort, but an infant's small body is especially vulnerable to opiates. A dose that seemed modest could cause profound drowsiness, interfere with feeding, and slow breathing. The quiet cradle that brought relief to an exhausted room might require urgent attention. The formulas were not always consistent, and household spoons were not precise instruments. One bottle might differ from another. One child might be more sensitive than the last. The danger could not be judged simply by looking at the amount of liquid. Doctors, coroners, and public investigators did raise warnings during the 19th century. The harm was not completely invisible, yet concern had to compete with poverty, long working hours, persuasive advertising, and the immediate human need for a crying child to sleep. At dawn, a careful doctor might remove the syrup from beside the cradle. The lesson is not that Victorian parents failed their children. It is that powerful ingredients, unclear labels, and desperate circumstances formed a dangerous combination. The fifth remedy arrived late in the Victorian story and was welcomed as a brilliant modern discovery. Cocaine was isolated during the 19th century, but its major medical excitement began in 1884 when its value as a local anesthetic was demonstrated. For eye surgery and later for dental and other procedures, the effect was genuine and transformative. A small area could be numbed while the patient remained conscious, avoiding some of the risks of general anesthesia. In a dentist room, the nervous patient had good reason to welcome it. For the first time, a painful procedure could be made far more tolerable. This was not an imaginary cure or an empty performance, but enthusiasm moved faster than caution. Coca extracts, cocaine toothache drops, lozenges, and tonics appeared in medical and commercial settings. Products promised energy, relief from fatigue, or freedom from pain. The distinction between a carefully applied local anesthetic and repeated personal use could become blurred. Brief stimulation might be followed by restlessness, anxiety, sleeplessness, and exhaustion. A weary professional who reached for another dose to finish the night's work could enter a cycle in which the remedy deepened the problem it appeared to solve. Warnings about toxicity and dependence appeared remarkably quickly. Physicians were already debating the new drug within a few years of its celebrated arrival. The same profession that admired its usefulness began looking for safer ways to obtain its anesthetic effect. Cocaine still has limited legitimate medical uses. Its history reminds us that a treatment may be truly effective and still become dangerous when promotion expands beyond evidence, dosing is poorly controlled, or novelty is mistaken for safety. The sixth remedy was not new at all. It had survived from an older medical world. Bloodletting rested on several changing theories. In earlier traditions, removing blood could be explained as restoring balance among bodily humors. 19th century doctors might instead speak of congestion, inflammation, circulation, or pressure. The language changed more quickly than the habit. A physician prepared a linen band, a basin, and a lancet. Other methods used cupping instruments or medicinal leeches. The procedure appeared deliberate and controlled. Every tool had a place. Every movement followed a ritual, and the visible result created the impression that something decisive had been done. Yet a weakened patient often had little strength to spare. Blood loss could worsen faintness, anemia, dehydration, or exhaustion. If the underlying problem was infection, removing blood did not remove the organism causing it. By the middle and later decades of the 19th century, routine bloodletting was already declining in Britain. It would be misleading to imagine every late Victorian doctor reaching automatically for a lancet. The retreat began earlier and happened unevenly. As clinical observation and changing ideas about disease weakened old confidence, still, the practice did not vanish at once. Textbooks, respected teachers, and memorable recoveries could preserve a treatment long after doubts had begun. When a patient improved, the bleeding received credit. When a patient died, the disease could be blamed. Modern medicine does use therapeutic blood removal for a small number of specific conditions, and medicinal leeches can help in certain reconstructive procedures. The difference is not the tool alone, it is the diagnosis, the measured purpose, and the evidence defining when it should be used. In the quiet sick room, the doctor looks from the pale patient to the closed lancet case. Sometimes progress begins not with a new treatment, but with the decision to leave an old one unused. The seventh remedy attempted to fight one pain by creating another. Counter-irritation was based on the idea that irritation placed on the skin might relieve trouble deeper in the body. A mild mustard plaster could produce heat and discomfort and was commonly applied for chest complaints or pain. Stronger blistering preparations used cantharides, derived from blister beetles. These were intended to raise a blister on the skin. The reaction was visible, immediate, and difficult to ignore. In an age when many diseases remained mysterious, visible action could feel more convincing than patient observation. There was a dangerous temptation in that visibility. If the plaster hurt, it seemed powerful. If the skin reddened or blistered, the remedy appeared to be doing its work. But the underlying infection or inflammation might continue unchanged. Concentrated mixtures, prolonged application, or repeated treatment could cause severe irritation and burns. Cantharides could also be absorbed and affect the urinary system and kidneys. The treatment added pain to a body already struggling with fever or weakness. Not every warming plaster produced serious injury, and controlled cantharidin preparations have narrow dermatological uses today. Once again, the difference lies in concentration, indication, monitoring, and restraint. When the harsh plaster was removed, the room might become quiet again. A nurse brought fresh linen, water, and a cooling compress. These comforts could not cure a severe infection, but they did not demand that the patient prove the treatment was working by suffering more. The eighth remedy changed surgery forever, even as it introduced a new kind of danger. Chloroform entered clinical anesthesia in Britain in 1847. It acted quickly, smelled less unpleasant than ether, and did not catch fire near a flame. Surgeons and patients immediately understood its great promise. An operation no longer had to mean conscious agony. Early administration could be simple. Drops were placed on cloth or gauze near the patient's face. The person giving the anesthetic watched breathing, color, and pulse, trying to judge the depth of unconsciousness. There were no electronic monitors, controlled vaporizers, or modern systems measuring the exact concentration inhaled. A change in airflow, the position of the cloth, or several additional drops could alter the dose. Chloroform could suddenly suppress breathing or disrupt the heart. Reports of unexpected death appeared soon after its introduction. Its speed and usefulness did not remove its narrow margin of safety. This does not make anesthesia a Victorian mistake. It was one of the century's greatest humane advances. John Snow and other careful practitioners studied delivery, designed inhalers, and worked to make the process more controlled. Dedicated anesthetists, improved equipment, physiological knowledge, and alternative agents gradually made operations safer. In the recovery room, a patient opens their eyes beneath a clean blanket. The nurse watches closely. The surgeon feels relief, but the chloroform bottle is returned to a locked cabinet. A medicine may deserve gratitude and caution at the same time. The ninth danger did not always pass through a doctor's hands. On a busy market street, a traveling seller displayed ornate bottles and promised relief for cough, pain, weakness, sleeplessness, stomach trouble, and nearly every other complaint that troubled the crowd. Newspaper advertisements made similar promises from the respectable safety of the breakfast table. So-called patent medicines were often proprietary mixtures rather than medicines protected by a true patent. Secrecy was part of their value. If the recipe remained hidden, competitors could not copy it. Unfortunately, the patient might not know what had been swallowed. Some preparations contained alcohol, opium, morphine, chloroform, cannabis, stimulants, or several active ingredients together. British products such as chlorodyne could genuinely reduce cough, diarrhea, and pain because their ingredients had real effects. Those same effects also created risks of sedation, dependence, an accidental overdose. Not every commercial medicine was fraudulent or poisonous. Some were harmless, comforting, or useful for limited symptoms. The deeper problem was uncertainty. A family could use two products without realizing that both contained related drugs. A patient might repeat a dose because the decorative label did not communicate its strength. The Pharmacy Act of 1868 introduced important controls for poisons, but proprietary medicines retained significant protection. Ingredient disclosure remained incomplete. Respectable packaging could therefore hide both a useful drug and a dangerous quantity. False confidence carried a second risk. A bottle promising to cure everything might delay isolation. Nourishing food, careful nursing, or medical attention. The illness continued while the advertisement received another chance. In the pharmacy, the chemist compares the ornate bottle with a measured preparation. Then he pushes the secret remedy aside. Safety begins when the contents of the bottle are no longer a mystery. The 10th remedy borrowed its authority from the newest force transforming the modern world. Electricity illuminated streets, carried messages, and powered machines. It seemed almost alive. If it could change a city, perhaps it could also restore a tired body. Medical batteries, hand-cranked machines, electrical belts, coils, and brass electrodes appeared in clinics and homes. They were promoted for pain, weakness, nervous exhaustion, indigestion, sleeplessness, and many unrelated conditions. The treatment was persuasive because the patient could feel it. A tingling hand or contracting muscle proved that the machine was doing something. Polished wood, wires, gauges, and shining metal gave the room the appearance of a laboratory. But sensation was not evidence that the cause of illness had changed. Some devices produced very little current. Others were capable of painful shocks, burns, or strong muscle contractions. The person operating the machine might understand electricity poorly, and the list of promised cures could extend far beyond any reasonable evidence. It would be wrong to dismiss every Victorian use of electricity. Physicians were seriously studying nerves and muscles, and electrical stimulation later gained valuable, specific medical applications. The danger lay in the cure-all claim, where one impressive force was offered for almost every diagnosis. A skeptical doctor disconnects the machine. The room becomes still. Instead of another shock, the patient receives water, rest, and a new examination. The choice looks less dramatic, but humility can be a medical skill. The 11th group of remedies gathered around one of the Victorian era's most feared diseases. Tuberculosis, often called consumption, could progress slowly. A patient lost strength, weight, and color. The cough remained. Families watched someone fade without understanding how to stop it. By 1882, Robert Koch had identified the bacterium responsible for tuberculosis, but knowing the cause did not immediately produce a cure. Effective antibiotic treatment remained decades away. Patients tried restorative tonics, cod liver oil, creosote mixtures, opiate medicines, and many forms of inhalation. Some products were sold with confidence far greater than the evidence behind them. Cod liver oil could provide calories to an undernourished patient. Opiates might calm a cough. Steam or aromatic vapors could ease dryness for a time. These effects mattered to someone who was suffering, but comfort was not the same as removing the infection. Strong mixtures could create new burdens. Alcohol or opiates added sedation. Expensive proprietary cures consumed a family's savings. The promise of recovery might delay precautions that protected other people in a crowded home. Sanatoria offered a different approach. Rest, fresh air, food, sunlight, nursing, and separation from dense urban life. These conditions could support the patient, and isolation could reduce exposure within the family. Yet the sanatorium did not reliably destroy the bacterium. On a coastal veranda, patients sit beneath blankets facing the sea. Warm drinks arrive. The air is clean and the routine is gentle. There is value in care even when cure is beyond reach. The danger begins when comfort is sold as certainty. Warm drinks arrive. The 12th and final danger waited not inside a bottle. But inside the hospital itself, surgery could remove a damaged limb, drain an abscess, or repair an injury. After anesthesia, surgeons could work with greater care and attempt procedures that had once been impossible. But before reliable antiseptic practice, the operating theater contained invisible hazards. Surgeons might work in ordinary dark coats. Instruments, sponges, hands, dressings, and tables could appear clean while carrying contamination from one patient to another. The operation might end successfully. The wound was closed, the patient returned to the ward, and the family felt hope. Then fever and weakness could appear days later. An unseen infection changed the meaning of everything that had happened in the theater. This was not simply personal carelessness. Germ theory had not yet reshaped every hospital routine, and the mechanism of infection remained debated. Practices differed between institutions and changed over time. Joseph Lister began applying antiseptic methods in the 1860s, drawing on new ideas about microorganisms. His system included treating wounds, cleaning instruments and hands, and using prepared dressings. The famous carbolic spray was only one part of an approach that continued to evolve. Adoption was uneven. Carbolic acid itself could irritate skin and tissue. Some surgeons resisted the theory, disliked the complicated routine, or failed to reproduce the results. But evidence accumulated, and better outcomes made old habits harder to defend. By the later Victorian decades, antisepsis was moving toward asepsis, not merely killing contamination after it arrived, but preventing it through cleaner rooms, washable surfaces, sterilized instruments, prepared clothing, and more disciplined routines. The quietest medical revolution may have looked like washing. A surgeon stands at a basin, an assistant prepares clean linen, instruments are placed in order. Nothing about the scene is as dramatic as a new machine or a mysterious tonic. Yet these repeated actions protect the patient in ways that the strongest bottle could not. Professional nursing also changed the sick room. Florence Nightingale and other reformers helped make nursing a trained, structured occupation. Ventilation, clean bedding, nourishment, hydration, drainage, and careful observation became parts of organized care. These measures did not replace specific treatment, and the theories used to explain them were not always complete. But a cleaner ward and an attentive nurse reduced avoidable suffering, while giving the body a better chance to recover. In laboratories, microscopes brought invisible structures into view. Bacteriology allowed physicians to ask whether a particular organism caused a particular disease. The answer did not arrive for every illness, and discovery did not instantly create treatment. Still, medicine was learning to test causes rather than rely only on tradition or testimony. Pharmacies also changed. Calibrated glassware, standardized preparations, professional registration, poison labels, and better disclosure gradually replaced some of the uncertainty surrounding household remedies. Reform was slow and imperfect, but a measured dose increasingly had to mean the same thing from one bottle to the next. The best physician did not simply exchange an old medicine for a new one. Safer care also required diagnosis, restraint, and the willingness to wait. Sometimes the correct decision was to nourish the patient, isolate an infection, monitor a fever, seek specialist help, or stop a treatment that was doing more harm than good. Roots. This is the deeper lesson of Victorian medicine. The past was not populated by fools. It was populated by people standing at the edge of what they could know. They observed real suffering and reached for the tools available. Their mistakes became visible because later generations learned how to measure them. Progress did not mean that every old remedy vanished or that every new one was safe. It meant that confidence slowly became answerable to evidence. Ingredients had to be named, doses had to be compared, outcomes had to be recorded. A respected tradition could be abandoned when patients did better without it. We have now passed 12 dangerous remedies: laudanum, mercury, arsenic. Infant soothing syrups, cocaine products, bloodletting, blistering agents, chloroform, secret medicines, electrical cure-alls, tuberculosis tonics, and surgery before reliable antisepsis. Some were largely harmful. Some brought relief but were used too broadly. Some became foundations of safer treatments once their risks were understood. Together, they reveal a century caught between the desire to act and the need to know. The pharmacy is closing now. One by one, the gas lamps are lowered. The brass scales are still. The strongest bottles are returned to the high cabinet, and the key turns quietly in the lock. Every bottle carried a human wish: to ease pain, silence a cough, calm a frightened child, or purchase one more peaceful night. Good intentions could not make every remedy safe, but they remind us why the remedies were trusted. Outside, the rain has stopped. The street is pale beneath the approaching morning. A physician and a nurse walk home while the last gas lamps fade into mist. You may leave the old pharmacy behind. The bottles are closed. The operating theater is empty. The city is learning, slowly, to question what it once accepted. And for now, there is nothing more you need to do. Rest well and good night.